Welcome to the deep dive. Today we're tackling a really important condition, type 2 diabetes mellitus.
Absolutely. Crucial stuff.
Think of this as your high-yield revision session. We want to give you those core insights you absolutely need.
Yeah, we've pulled together information from various sources to make it comprehensive, but, easy to digest.
Our mission is basically to pull out the what, why, and how of type 2 diabetes, make it stick.
Exactly. We'll cover the definition, the causes, risks, how it works in the body.
Pathophysiology, yeah.
Right. Then differentials, how common it is, symptoms, tests.
Management, prognosis, complications, the whole lot.
Let's jump right in.
Okay, first things first. The definition. What exactly is type 2 diabetes?
So fundamentally, it's a chronic metabolic disorder. Two main things are going wrong.
Okay.
One, your body's cells get resistant to insulin.
Right.
They don't listen to it properly.
Insulin resistance, right.
Exactly. And two, over time, the pancreas might not make enough insulin to compensate, so relative deficiency.
Leading to high blood sugar.
Precisely. Hyperglycaemia, and problems with glucose metabolism overall. And importantly, unlike type 1, it's generally not autoimmune.
So the body isn't attacking itself in the same way.
Correct. Type 1 involves that autoimmune attack on the insulin-producing cells. Type 2 is more about the cells ignoring the insulin, at least initially.
It usually starts later in life.
Typically, yes, though we're seeing it worryingly more in younger people now, too.
And it's common.
Oh, hugely. It accounts for something like 90% of all diabetes cases.
Wow. You mentioned other types earlier, just briefly. Anything key to remember there?
Well, you might encounter things like MODY, that's a genetic form, or secondary diabetes from other conditions or drugs. There are even new ways being proposed to classify diabetes.
But for today, we're zeroing in on type 2.
Exactly. Keep those others in the back of your mind. But type 2 is our focus.
Got it. So what actually causes it? The etiology?
It's multifactorial, meaning it's a combination of your genes and your environment, your lifestyle.
Okay, so genetics play a part.
Definitely. A family history significantly bumps up the risk. Some sources say maybe a 2.4 times higher risk if a close relative has it. Yeah, there's a definite predisposition.
Right. And the environmental side.
That's massive. A sedentary lifestyle, not moving enough, is a big one.
Makes sense.
And diet, especially diets, high in processed stuff, sugary foods and drinks.
Mm-hmm.
Obesity, particularly carrying extra weight around your middle, is a major driver. And simply getting older increases risk, too.
So it's this complex mix. How does that actually, work inside the body? The mechanism?
The core issue is that insulin resistance we mentioned. Think of insulin as a key, trying to unlock your cells to let glucose in for energy.
Okay.
With resistance, the lock gets sticky. The key doesn't work as well. Glucose can't get into the cells easily, so it builds up in the blood.
Right.
Initially, your pancreas works overtime, pumping out more insulin to try and force those locks open, like shouting louder.
Trying to compensate.
Exactly. But eventually, those beta cells in the pancreas, the ones making insulin, they can get exhausted or damaged. They just can't keep up the high production.
And that's the relative deficiency part.
That's it. So you end up with both resistance and not enough insulin.
Okay, that clarifies the process. So who is most at risk? Let's list those key factors.
There are quite a few. A good way to think about some major ones is maybe the mnemonic OBESITY-FAMED deal.
Okay, let's break that down.
Obesity, especially central or truncal around the waist,
Yeah.
being from certain ethnic groups. We know South Asian, African, African Caribbean, Polynesian, Middle Eastern, and American Indian populations have a higher risk.
Yeah.
Elderly age, risk increases as you get older. Sedentary lifestyle, lack of physical activity.
Right.
Impaired glucose tolerance, IGT, or impaired fasting glucose, IFG. Those pre-diabetes states. Certain treatments, like thiazide diuretics combined with beta blockers, can increase risk.
Yeah.
You had gestational diabetes during a pregnancy, that increases your future risk. Family history, as we mentioned.
Yeah.
Adults who had a low birth weight for their gestational age.
Mm-hmm.
Metabolic syndrome, that cluster of conditions like high blood pressure, high cholesterol, obesity, eating a diet low in fiber, and high glycemic index foods. Certain drugs, again, like thiazides or corticosteroids. Inactivity, linked to sedentary lifestyle.
And L.
Low birth weight, same as A. And we should also add polycystic ovary syndrome, PCOS, to that list. It's strongly linked.
That's a comprehensive list. So we've covered who's at risk. Let's revisit the pathophysiology, how it really messes with the body.
Right, it's that dual hit we talked about, worth hammering home. First, insulin resistance. Muscle, fat, liver cells, they just don't respond well.
So glucose stays in the blood.
Yes, especially after eating. The pancreas tries to compensate, leading to high insulin levels, initially hyperinsulinemia.
But that doesn't last.
No, that's the second hit. The pancreas eventually struggles.
Yeah.
Beta cells can get worn out, maybe even die off to some extent, and can't produce enough insulin to meet the body's needs.
So resistance plus not enough insulin production.
Exactly. And it's not just about sugar. Fat tissue itself, especially when there's excess, releases hormones and inflammatory cytokines.
Well, right. It's metabolically active.
Very much so.
That's it.
And these substances can actually worsen insulin resistance and contribute to other problems like cardiovascular disease. It's all interconnected.
Okay. So if someone presents with high sugar, how do you tell it's type 2 and not something else? The differentials.
Good question. You need to rule out other things. Maybe think LTS for key ones.
LTS.
L for LADA.
Oh.
Latent autoimmune diabetes in adults. It's autoimmune, like type 1, but comes on much more slowly, often in adults, so it can look like type 2 at first.
Okay.
Type 1 diabetes itself, especially if symptoms come on quickly or in a younger person, though type 1 can occur at any age.
And S.
Secondary causes, diabetes caused by something else, like diseases affecting the pancreatitis, for example, or endocrine disorders like Cushing's syndrome or acromegaly, which affect hormone levels, and definitely drug-induced diabetes, particularly from corticosteroids.
So steroids are a big one to watch out for.
Absolutely. A careful history is crucial to pick these up.
Right. What about how common type 2 is? The epidemiology.
It's extremely common. The most prevalent form of diabetes globally and certainly in the UK.
Makes up that 90%, yeah.
Exactly. Prevalence climbs steeply with age, and as we said, driven by lifestyle, obesity rates, and those ethnic predispositions.
Any specific numbers for the UK?
Current estimates are around 3.9 million diagnosed cases in the UK, but there's a strong suspicion there are many, many more walking around undiagnosed.
That's a huge public health issue. So what symptoms might bring someone to the doctor? The clinical features?
So you've got the classic 3Ps often mentioned.
Polydipsia.
Polyuria and polyphagia. So increased thirst, frequent urination, and increased appetite.
Got it.
But it's often more subtle. Unexplained weight changes could be loss, could sometimes be gain, feeling tired all the time, fatigue. Blurred vision is quite common. Also, slow healing of wounds, cuts, or bruises. And getting frequent infections, things like urinary tract infections or yeast infections like thrush.
Right. The high sugar feeds the bugs.
Sorta, yeah. It affects immune function too. And sometimes the first sign might actually be a symptom of a complication, like tingling or numbness from nerve damage.
But sometimes no symptoms at all.
Exactly. Especially early on. It can be quite insidious, quite sneaky, often picked up incidentally on blood tests done for something else entirely.
So you need tests to be sure. What are the key investigations?
Diagnosis relies heavily on blood glucose measurements. A fasting plasma glucose, or FPG, is key.
Fasting means no food for.
Usually at least 8 hours. If that level is 7.0 millimoles per liter or higher on 2 separate occasions, that's diagnostic.
Okay. What about non-fasting?
A random plasma glucose test can be done anytime. If it's 11.1 or higher, and the person has symptoms of diabetes, that's highly suggestive.
Right. And the sugar drink test.
The oral glucose tolerance test, the OGTT. You drink a standard 75-gram glucose drink, and they check your blood sugar 2 hours later.
And what level indicates diabetes there?
A level of 11.1 millimoles per liter or higher at the 2-hour mark confirms diabetes.
Okay. Then there's HbA1c. How does that fit in?
HbA1c is incredibly useful. It gives an average picture of blood sugar control over the previous, say, 2 to 3 months.
Like a longer-term snapshot.
Exactly. A level of 48 millimoles per mole, which is 6.5% or higher, is also diagnostic criteria for diabetes. And we use it a lot for monitoring treatment effectiveness, too.
But you can't always use it.
Correct. There are important situations where HbA1c isn't reliable, things that affect red blood cells or hemoglobin turnover.
Like
Hemoglobinopathies like sickle cell, hemolytic anemia, untreated iron deficiency anemia can skew it. Suspected gestational diabetes, use in children, people with HIV, significant chronic kidney disease, these can all affect the result. And recent steroid use too.
Good list to remember. Any other tests?
Well, a urine dipstick might check for ketones. High ketones could mean very poor control or even DKA, though DKA is less common in type 2 than type 1.
Right.
We'd also typically run tests to check kidney function, urea, and electrolytes, or UNEs, liver function tests, LFTs, thyroid function, TFTs, and a lipid profile for cholesterol.
Getting the bigger metabolic picture.
Exactly. And then there are tests for complications, regular eye screening, foot checks for neuropathy, cardiovascular risk assessment. Oh, and important to mention the prediabetes stages too.
IFG and AGT.
Yes. Impaired fasting glucose, IFG, is a fasting level between 6.1 and 6.9. Impaired glucose tolerance, IGT, is a fasting level below 7.0, but the 2-hour OGTT result is between 7.8 and 11.0. Identifying these helps target prevention efforts.
Crucial for catching it early. Okay, so we have a diagnosis. What's the management plan?
It's really multi-pronged. Lifestyle is the absolute cornerstone.
Diet and exercise.
Healthy diet, regular physical activity, and aiming for a healthy body weight. Absolutely fundamental. This is step one for everyone.
Makes sense. Then medications.
Yes. Metformin is typically the first-line drug. It works mainly by improving insulin sensitivity and stopping the liver releasing too much glucose.
How's it usually started?
Often start low, go slow. Titrate the dose up gradually to minimize side effects like stomach upset. There's also a modified release version which can help with that.
And other drugs. You mentioned SGLT2 inhibitors.
Yes, drugs like dapagliflozin or empagliflozin, they are increasingly important, especially for people with established cardiovascular disease, heart failure, or high cardiovascular risk, because they offer protective benefits beyond just lowering sugar. NICE guidelines often recommend considering these early on in such patients.
So treatment is becoming more personalized based on risk.
Very much so. It's not just about the HbA1c number anymore. It's about the whole person and their other health issues.
Speaking of HbA1c, what are the targets?
They need to be individualized, agreed between the clinician and the patient. Things like age, frailty, risk of hypos all play a part.
But generally?
Generally, NICE suggests aiming for an HbA1c of 48 millimoles per mole, 6.5%, if managed with lifestyle alone or just with metformin.
And if other drugs are involved?
If a drug that can cause hypoglycemia, like a sulfonylurea, is added, the target might be relaxed slightly, maybe to 53, 7.0%, to balance control with safety.
How often is it checked?
Usually every 3 to 6 months after diagnosis, or if treatment changes, then maybe every 6 months once stable.
What if metformin and lifestyle aren't enough? If HbA1c is still high, say over 58, 7.5%.
Then you move to dual therapy. Add a second drug. Common options include a DPP-4 inhibitor like sitagliptin, a sulfonylurea like gliclazide or pioglitazone, or an SGLT2 inhibitor if not already started.
And if 2 drugs aren't enough?
Triple therapy is considered, combining metformin with 2 other agents from different classes, or potentially moving towards injectable therapies like GLP-1 receptor agonists, like liraglutide or semaglutide or insulin. GLP-1s are often added under specialist guidance.
Lots of options. You also mentioned managing other risk factors.
Yes, absolutely critical for preventing complications. Managing blood pressure as key target is usually the same as for non-diabetics, often aiming for below 1490 or lower if there's kidney or eye damage.
What drugs for blood pressure?
ACE inhibitors, like Rambrel, or ARBs, like losartan, are usually preferred first line, especially if there's kidney disease, because they offer some kidney protection.
And cholesterol.
Statins are usually recommended for primary prevention if the 10-year cardiovascular disease risk is 10% or more, and for almost everyone with established CVD, secondary prevention.
Any role for aspirin?
Generally only for secondary prevention now. So if someone already has cardiovascular disease, not usually recommended for primary prevention in diabetes anymore due to bleeding risks outweighing benefits in most.
This is a very holistic approach. What about prognosis? What's the outlook?
It really varies hugely. It depends massively on how well blood sugar is controlled over the long term.
And managing those other risks?
It's exactly.
Yeah.
Blood pressure, cholesterol, lifestyle choices, they all have a huge impact. Early diagnosis and sticking to the agreed treatment plan are key.
So good management means a better outlook.
Definitely. People with well-controlled type 2 diabetes can and do live long, active, healthy lives. But it requires ongoing effort and engagement.
Which brings us to the flip side. What happens if it's not well controlled? The complications.
Yeah, this is the serious part. Complications can be acute, meaning short-term crises, or chronic, developing over years.
Acute ones first.
The main one in type 2 is hyperglycemic hyperosmolar state, or HHS. This is severe dehydration and very high blood sugar, but usually without the high ketones seen in DKA. DKA can happen in type 2, but it's less common than HHS or than DKA in type 1.
Okay. And the long-term chronic ones.
These affect many parts of the body. Broadly, you have macrovascular complications affecting large blood vessels.
Like heart attacks and strokes.
Exactly. Cardiovascular disease is the biggest killer in type 2 diabetes. Also, peripheral artery disease, affecting blood flow to the legs and feet.
And microvascular.
Small vessels?
Yes. Diabetic retinopathy, damage to the blood vessels in the eyes, which can lead to blindness if untreated.
Scary.
Diabetic nephropathy, kidney damage, which can progress to kidney failure requiring dialysis or transplant. And diabetic neuropathy, nerve damage.
How does neuropathy show up?
Can cause pain, tingling, numbness, often starting in the feet and hands. It can also affect nerves controlling digestion, heart rate, sexual function, autonomic neuropathy. And it contributes massively to foot problems.
Foot ulcers.
Yes. Reduced sensation from neuropathy plus poor circulation from peripheral artery disease makes foot injuries more likely and harder to heal, leading to ulcers and potentially amputation if infections set in. People with diabetes are also generally more prone to infections.
It really highlights why tight control and regular checks are so vital.
Absolutely. Prevention and early detection of complications is a massive part of diabetes care.
Okay, let's try and summarize the key takeaways from this deep dive. Type 2 diabetes. It's insulin resistance, then not enough insulin, leading to high blood sugar. Right. Caused by that mix of genes and lifestyle, obesity, inactivity, diet, age, ethnicity are big factors. Remember, obesity-famed DIL.
Diagnosis via blood glucose or HbA1c, but remember HbA1c limitations. Differentials include LADA, type 1, and secondary causes, LTS.
Management cornerstone is lifestyle, then usually metformin, maybe SGLT2 inhibitors early for high-risk patients, then step up treatment as needed, aiming for individualized HbA1c targets.
And critically, manage blood pressure, cholesterol, and other cardiovascular risks. Check eyes, kidneys, feet regularly.
Prognosis is much better with good control, but poor control leads to serious macrovascular and microvascular complications.
This has been incredibly useful, especially for revision. Really high yield.
Hope so. And for those listening who want to dig deeper, NHS UK, diabetes.co.uk are good patient-facing resources, and the Oxford Handbook is great for clinical detail.
And if you're prepping for the MSRA exam, definitely check out PassTheMSRA.com and the free resources at freemsra.com.
Absolutely. Worth remembering that our understanding is constantly improving new drug classes, better understanding of mechanisms. It's a field that keeps moving forward.
It really is. A huge thank you for sharing all that insight. And thank you all for listening to The Deep Dive. We'll catch you next time.